Very good morning to all of you. I heartily welcome you to this instruction course on endophthalmitis. Endophthalmitis is one of the most dreaded complications of any intraocular surgery, and certainly you do not want to land up in a situation like that. But if you really have a case of endophthalmitis, you must know how to diagnose it, how to treat it, and most importantly, how not to have another episode of that. So if you're looking for all that, you have come to the right place. Here we'll be talking about all the recent protocols and guidelines that will help you to prevent endophthalmitis and also how to diagnose and treat them. So this is the outline of our course. I am Dr. Haimanti Choudhury, cataract and oculoplastic consultant working in Choudhury Eye Hospital and Research Center, Silchar, Assam. I have the opportunity to introduce my co-instructors. Dr. Satangshu Mathur is consultant ophthalmologist, High-Tech Eye Institute and Laser Center, Kashipur. He is the chairman scientific committee of AIOC, national coordinator of IS-MSICS, and the convener of the extremely successful SSTC courses. Dr. Deepak Mishra is the assistant professor, RIO BHU, Varanasi. He is the chairman scientific committee of UPSOS and the convener of SSTC. Dr. Haimanti Choudhury is the vitreoretina consultant, Choudhury Eye Hospital and Research Center, Silchar, Assam. Dr. Jalpa Vasi is the consultant ophthalmologist, Manipal Hospitals, Bangalore, and NABH assessor. And last but certainly not the least, Dr. Ajay Arora is the vitreoretina surgeon, Vision Plus Eye Center, Noida, and he's also the joint treasurer of AIOS. May I request all my co-instructors to please come on the stage, and Dr. Mathu sir will start on the pre, per, and post-operative measures to prevent endophthalmitis.
So, Haimanti, good morning, and Dr. Alpa and all the Deepak. Well, so we are going to speak very important topic, but unfortunately, this should have been learned by all the newcomers especially, but they are busy in the night parties and so they could not come. So what are the possible factors, alone or in combination, are responsible for endophthalmitis? It is a deadly disease, and if we take simple precautions, we can really avoid this thing which is nightmare for any eye surgeon. So 5 possible factors are there, alone in combination. If we take care of these factors, we can save the eye of the patient. Personal hygiene, environmental surgical supplies, contaminated surgical supplies, faulty sterilization procedures, inadvertent touch, environment. So we will take one by one. What are the preoperative risk factors? This is external examination, blepharitis, conjunctivitis, lacrimal obstructions, and recent immunosuppressive treatment, and eyelid abnormalities. And most important is the diabetes. So we should take care of these things as a preoperative risk factors whenever we are going to operate the case. These are the, whatever I am going to tell you, this parameter, these are the Aos Recommended Parameters. If you mention this in the court, you are saved. Blood sugar fasting less than 120, random less than 200 mg%. You can operate any case, there will no trouble for you. Conjunctival culture, history of chronic infection, recently healed corneal ulcer, urine routine microscope examination. But syringing should be done not on the same day. If you have to do the syringing, it should not be done on the same day. If regurgitation is positive, then we should avoid the surgery. What the instruction we should give to the patients? 4th generation broad spectrum antibiotic, 4 to 6 times a day before surgery and on date of surgery. No need of giving antibiotic preoperatively for 2 or 3 days. Patient should come with face wash, hair with soap, male should come with clean shaved, and they should wear their clean clothes. What instruction you should give to the patient, staff? If biometry has to be done on the same day, use immersion method. Never use contact method for biometry if I to done on the same day. If you have a list of 10 patients and they are diabetics for patient 1 or 2, you should operate diabetic patient first, as chances of infection are more in them. How to prepare the patient in the OT to save from yourself from endophthalmitis and save the eye of the patient. So clear the brow region and lid margin with 10% povidone. We should not clear only the eyelid. We should clear all around the eye up to the nose with iodine 10%. Then iodine 5% 2 times topically 5 minutes before surgery is more important than giving antibiotic 1 day before the surgery. So remember thinking iodine 10% for cleaning and 5% for local sterilization is more important than anything else. Then we should change all the clothes in the OT that we are doing. The scrubbing very important. This chart should be hanged over the washing area because this is not important for you but for your staff to know, OT assistant to know that he has to wash for 5 minutes. Nobody of us wash for 5 minutes. I have myself noted hardly 1 or 2 minutes we take and then go for the OT. So we should give proper time scrubbing to save our more important time later on if infection happens. Iodine liquid scrub, chlorhexidine antibiotic soap up to the elbow we should clean. Gloves should be proper. Dipping is very important to prevent the infection. Should check expiry date and packing whether it is intact of all not by all the supplies. Your assistant should be aware of this thing. Before giving to you, he should check the intact supplies or not and then expiry date. Irrigating fluids, we should note the batch number and we should physically inspect against the light to see any foreign body is there or not in the liquid. Well, most of the time we have found the irrigating fluid is the culprit in infection. Please preferably keep infusion bottle for 24 hours after use. If there is an infection, you can get it checked. Phaco sleeve and tissue should be changed after each case, but we are not doing in India. We can use 2 or 3 cases, but ideally it should be changed every case. There is no evidence that using antibiotic in irrigating fluid will help. So we have stopped giving antibiotic in the irrigating fluid nowadays, as moxifloxacin at the time end of surgery we can give. Subcutaneous antibiotic given at conclusion of surgery have been found to reduce risk of endophthalmitis. Intracameral injection of the antibiotic is helpful, must use in high-risk cases at least, but now we are using almost all cases. That Haripriya from Arvind Hospital has a long research of the long 20,000 patients almost that it has helped. Incision should be watertight, and we should manage the complications. If there is a PC rupture, we should do the vitrectomy, at least anti-vitrectomy. We should not leave case as such, because the vitreous tag is there in the wound area, it will cause infection. Post-operative schedule, we call patient first day, 7th day, 21st day, and then we prescribe the glasses and everything. Examination should always be done at least on the first visit on the slit lamp. We are giving topical broad spectrum antibiotic for 7 days, oral only in high-risk cases, especially diabetes, and topical steroids tapered in 21 days. So treatment schedule is almost changed nowadays. Nobody is giving antibiotic for 21 days or 1 month. We give protective glass for some time. If you have a doubt of the infection, you should talk to the patient, relate to a patient. That will be taken care of by the next speaker. And we should institute proper treatment. We should not panic. And we should take the help of other doctors, authorities. My schedule of cleaning of instruments, microscope head, phaco, cautery, should be cleaned daily with antiseptic after the OT with the antiseptic liquid, that is chlorhexidine, cetrimide solution. We can dilute it and use. It should be duty of the OT assistant. OT layout, there will be discussed detail. I am just taking it. It should be away from the public movement. It should have areas. You are covering it, Amade? So I will be skipping this thing. But most important thing is culture sensitivity. Once a month, samples from floor, walls, OT table, AC, phaco machine, and should keep record. This will save you in the court of law. If there is any problem, infection happens, you can say, my instruments were clean, I have no fault, my OT was clean. So you should keep this. And we should restrict number of persons. Your person should not keep moving in the inside and outside the OT. Water tank is very important. Nobody take care of the water tank. We have never gone to the top of the floor and see what is the condition of the water tank. So we should have a small separate water tank for our OT because it is an important reservoir of microorganisms and pseudomonas, which is dreaded organism. Advisor to treat water at user end by some means. Water tank cleaned and bleaching powder once a month. It should be documented. I keep a register where so that I know when it was cleaned before. So documentation is very important for NABH and for the court. These checklists are very important. We should have daily checklists. Who checked the preoperative, who checked autoclave strip, who filled the drum of gowns, who checked clarity of injection, who did preparation before arrival of surgeon. These all things are very important just to make the staff aware and that the staff is doing things regularly. This is signed by the OT assistant, then it is countersigned by me. So they are really worried that Dr. Sahab can see it, so they are doing their duty. Who did cleaning of OT after leaving us? Who cleaned equipments? Who put on the air sterilizers? Who checked the anesthesia trolley? Who replaced these all things you can note down, and it should be a register daily after OT. It should be before the OT should be signed, and after the OT you should sign this. This is a weekly checklist. List of medicine checked, who by whom, emergency medicines. IoT check, who submitted autoclave report. We have a register for autoclave report where we keep daily autoclave report. We keep it, there is a strip of the registration will deal here. We keep that strip in the autoclave register. That is also helpful in the court if there's something wrong happens. Who the cleaning are done, who cleaned the walls of OT up to 4 feet. So these all things are weekly checklist. You see, we are not using now, it is not allowed nowadays, the split AC, etc. But if you are having the split AC, then you should clean the filter daily, routinely. Who clean the instruments? The staff hygiene is very important. Their nails and their clothes, they should have no infection in the hood. Installation of autoclave machine, who done, we autoclave the instruments, but nobody take care of the autoclave itself. So they are biological indicators to get clean the autoclave. Who checked it at least once a week or once a month? Expiry date of medicines, and then special note, signature of OT in charge and signature HOD. So these things are very important, and we should really check it. The monthly checklist. Who take the swab culture from wall, floor, OT table, and we should keep in the record. And you can check this register once in a month that things are done regularly or not. Who cleaned the OT? Who did in charge check the washing of OT on the last Saturday? So these things are the important things, not for you, at least for the staff, to keep them on their toe every time. Who clean the water tank? And documentation is very important for NABH and for yourself, peace of mind. So these things should be seen, and this should be signed by you. If you take care of all these things, I know your patient will be happy and you will be happy. So just simple precautions that we all know, but sometimes we really neglect it. So we should not neglect it, and then you can save yourself. Thank you.
Thank you, sir, for the wonderful talk. Now I invite the Chief Instructor of this IC, Dr. Haimanti Choudhury, and
Thank you very much, Dr. Satangshu Mathur, for this wonderful presentation. For your convenience, we have got many handouts, so it'll be very beneficial if you want to take them. I have placed them in the front of the dais. Whoever wants a handout can take it. We also have some more. If it is finished, don't be worried. I'll give you. I have more with me. I once again welcome all of you to this instruction course in endophthalmitis. And I'll be talking on operation theatre layout.
वो एक्सटेंड मोड पे होगा क्या आपका लैपटॉप?
ये ऑफ करके नहीं तो फिर से एक बार on कीजिए। हाँ, आ गया। आ गया था ना? We have no financial disclosure in this presentation. So why at all do we need a OR layout? To get approval by government and professional bodies like the NABH, it improves the safety profile for our patients, the staffs and providers. It improves the quality of the hospital, improves our image. On the long run, it saves on the maintenance cost, on the HR cost, and in this era of violence against doctors, it saves us from medical negligence. So it will be discussed under two heads. One is the infrastructural and engineering control, which starts prior to the building design of the OT, and the managerial control starts after the OR has been constructed. Prior to the construction of OR, we have to have a knowledge about the proper architecture and planning, zoning, and heating, ventilation, and AC system. Managerial control will deal with disinfection, sterilization, validation, and biomedical waste management. While we are planning an OT, it should have functional segregation from the OPD, indoor, and the laboratory services. Preferably, the location should be top floor of the hospital that you are working in. It should not have too much of movement of patients around. The construction material goes without saying that should be long-lasting, easy to maintain, and resistant to microorganisms. All OT complexes have 4 zones. One is the protective zone, which will consist of the transfer base, the changing room, the records room. Second is the clean zone, which is the intermediate zone between the protective and the sterile zone. Third is the sterile or the aseptic zone, which is the OR proper, where we are doing the surgeries. And the fourth is the disposal zone, where we'll do the processing of all the instruments and the soiled articles will be received. The protective zone, the clean zone, and the sterile zone. Coming to the ventilation, this is an AIOS guidelines which was given in 2018, and in this guideline they have mentioned that central AC is not a must. Split AC is okay. There cannot be any window AC, cannot be any fan. HEPA filters, till now there is no consensus of benefit, but if somebody has an air handling unit, it is a great advantage. Water tank has been talked about by Dr. Mathur. All IoTs should have a separate water tank, and it should be cleaned monthly, and it should be recorded. What we will do is first wash with 7% povidone iodine cleansing solution, and then we have to treat the water at the user end, that is then we wash with the AquaGuard water. Finally, we use an alcohol-based hand sanitizer or a sterilium. This is something that we always use, and this povidone iodine drop, no financial interest, we put in the eye preoperatively just prior to the draping. These are the minimum standards for IoT given by NABH, 260 square feet of space, but AIOS guidelines have made this 160 square feet provided the number of persons working in the OT is 4. Humidity again 40 to 60%, temperature 21 plus minus 3 degrees. Positive pressure, occupancy should be limited, and it should have sufficient lighting. Floor surface should be seamless, non-porous, smooth. It should be easily cleanable repeatedly. OT doors should be self-sealing with a closer like this so that you don't have to hold with the hand. The walls should be moisture-proof, light should be good, and since we have so many costly instruments like the vitrectomy machine, phaco machine, this all OT should have a separate power circuit and an UPS backup. For those who can afford the modular OT, it is certainly best. It is pre-designed, engineered with guaranteed performance. It has a vertical laminar flow and the environment is very comfortable to work with. This is the fourth zone, the disinfection room, where we will process the soiled articles. We need to have a wash basin, a discharge table, a flusher disinfector, and clean storage shelves. Coming to the second part of my talk, sterilization, we all know that major source of infection is the instruments, so proper cleaning and reprocessing of instruments cannot be overemphasized. Sometimes we spend lakhs of rupees on the instruments, but we might not get a very good autoclave. So spending on a good autoclave is a very good idea. Cleaning process has to start immediately after the surgery is going on. So you need to have two sets of staff. One will be helping you in the OR, and the second set of staff will be doing the reprocessing of instruments. What we do is we separate the sharp and blunt instrument first. Then these forceps, as you see, these are the needle holder, the corneal suture, which has a lock at the posterior part that is opened so that you get access to the joint, and these joints should be cleaned with soft bristle brush, and it is dipped in distilled water. It is cleaned thus. Then processing in ultrasonic cleaner is done. We also like to dry our instrument. I come from an area which is a 70% humidity, so any amount of moisture left in the instrument leads to rusting. So we always dry our instrument with a hair dryer, with a simple hair dryer. Then they are double dipped. We use the 4-bowl technique, double dipped in cetrimide and chlorhexidine solution. 2 trays, then they are put back in 2 more trays having distilled water. The instruments after drying are packed in this pattern like sets, like vitrectomy sets, cataract sets, and glaucoma sets, and they are kept in this stainless steel boxes waiting to be autoclaved. Processing of hollow instrument is little different from others. By hollow instrument, I mean the phaco tubings, irrigation aspiration cannulas. It has to be flushed with distilled water. Please note distilled water and not tap water. The flushing here is being done by my sister with a 60 cc syringe. It is always better than a 10 cc syringe. You do 3 times flushing with 60 cc syringe, flushing with distilled water, followed by flushing with air, and then it goes for sterilization. Packing again is different for steam autoclaving and for ethylene oxide. For steam autoclaving, you need to put those chemical indicator strips inside the box of the stainless steel, then in the outer cover as well, and in the strip, please mention the date and the time of when you're putting. And it's supposed to change color after autoclaving is done. For processing and packing for ETO, these are the rolls that you see. These rolls are cut according to the size we want. These rolls have marking. These change color after ETO has been done. This is the sealing machine. So what are the sterilization methods that should be followed? For linen and metallic instrument, it is steam under pressure, horizontal or vertical, but always vertical, horizontal autoclave is preferred. The autoclaved instruments should be used within 48 hours. And in between cases also the autoclave should be used and it should be documented. Class B autoclaves are very good for long tubings, and AIOS does not recommend chemical sterilization anymore. Ethylene or ETO gas sterilizer is also something that we use because we have a lot of heat labile instruments like phaco tubings, vitrectomy probes, cryoprobes, and some vitrectomy lenses, which has to be sterilized in the ETO. It has a running time of 6 hours, and after sterilization, an aeration period of 72 hours is a must, and the sterility is maintained for 1 year. So these are some of the instruments which we sterilize in this ETO. Coming to the indicators, the physical indicators are the temperature and pressure, how much is reached in the autoclave, which you can see in the indicator present in the machine itself. Chemical indicators are these strips, as I have mentioned. These are the autoclave strip, these are the ETO strips. And we also have these Bowie test, which is very good to know whether the hollow tubing sterilization is perfect or not. These are biological indicators which test how good our autoclave is functioning. Then coming to the cleaning protocol of operating room and corridor. Sir has already mentioned that floor, OT floor, microscope, surfaces and sinks should be cleaned daily, and it should be documented. No sweeping or dry dusting, only wet mopping. The AC filters should be cleaned weekly, and servicing should be done every month. This is our preferred technique of cleaning the OT floor. We use a 3-bucket system. In 2 buckets, it is clean water, and in the 3rd bucket, we have a disinfectant. In our case, we use Bacillocid. Coming to the OR room fumigation, formalin fumigation is not preferred nowadays because formalin is carcinogenic. The best would be D125, which is a quaternary ammonium compound. But having said that, AIOS has still not contraindicated formalin fumigation. According to the protocol that they have mentioned in the recent guidelines, it is for a running OT, fumigation should be once a week. For a startup OT, fumigation on 3 consecutive days, followed by 3 negative culture. Fogger machine is preferable, though not mandatory, and periodic culture for a running OT should be done in 3 monthly interval. When you are doing periodic culture, the swab should be taken from the microscope head end of the table and the OT air, and all these findings should be documented. These are the new disinfectant, as I have mentioned, Bacillocid or Desnet. Then ultraviolet radiation, many are also using. If you are using that, you have to switch that on for 14 to 16 hours every day, and it is switched off 2 hours before entering the OT. So this is the cleaning protocol. I'll not go to the details. For those who want, I have handout. You can take that, and you can just stick it to your OT if you wish. Coming to the post-COVID era and how we are dealing with our patient in the post-COVID era, staff training is something which is very important. You have to train your staffs at regular interval of what they should do and not do. This is the national guidelines for infection prevention and control, and this is the hierarchy of controls of how to prevent ourselves and our healthcare workers. The first 2, of course, doesn't work for us, which is the elimination and substitution. That is, you don't allow the virus to touch us, but that is not possible because since we are working out. So for us, engineering control and administrative control is something that should be dealt with. And personal protective equipments, of course, judicious use of PPEs. This is a good read in the AIOS for the preferred practice protocol, which was published. If you wish, you can have a look at that. The level of PPE, I would say what we are using now is we use double mask. The first one is I have a photograph. The first one is a 3-ply mask, and the second is an N95. And also I want to emphasize that I'm sticking the upper end with a Medport tape. And this is an extra thing that we have started using after the COVID is goggles. For all your staffs, hand hygiene, respiratory etiquette must be taught properly. Protect yourself, staff and community. Triage of patients and inpatients should be done. Judicious and appropriate use of PPE, as I already said, and some home care precaution. This is also something which we have started doing extra. We did not do it before. We give a new mask to all patients before entering the OT, and we also stick a Medport tape at the upper part of the mask before he goes for operation. Thank you very much for your kind attention. And I'll call my next speaker, Dr. Deepak Mishra. He will talk on diagnosis and differential diagnosis of TAS. And I again request, if you wish, you can have the handouts. The handouts are here in the front. We have some more also. Dr. Deepak.
So whoever come late, they can take these handouts. It is lying here. You can take it out. All the talks, all the parameters have been, we have written here. So now we invite our next faculty, Dr. Deepak Mishra. He is a associate professor in BHU, and he will be speaking on clinical diagnosis and DD. So he is this is very important to differentiate between TAS and the endophthalmitis. And one thing I advise, even if you in doubt, always treat it as a endophthalmitis. So Dr. Deepak Mishra, he is the chairman scientific committee of UP, and also the very active member and the convener of SSTC, where we are giving the training of surgical skill transfer course. Deepak Mishra.
Thank you, sir, for the wonderful introduction. And thank you, Dr. Choudhury, for involving me in this IC, which is very much important for everyone, from resident, from general practitioner, from institutional people. What we usually fear is only one of the disease that is much more for all cataract surgeon, non-cataract surgeon is endophthalmitis. It is something which even the names fears most of the ophthalmologists, that no one like to hear this name in his or her case. So with these notes, there is no financial interest. I will start. What are the common reasons are the things which we have to diagnose or differentiate when we suspect a case of endophthalmitis? There are many, but my topic is only related to the TAS, which is much similar and associated with endophthalmitis. Other reasons in these cases are lens-induced uveitis, inflammation left out sometimes by some cortical matter or something else. It may be looks like in cases of masquerade syndrome and vitreous hemorrhage, but we will discuss our talk in differentiation between endophthalmitis and TAS, which is very much important. Now coming to the TAS. TAS is something which is the term coined by Monson in 1982, and it is something a sterile kind of inflammation. It is not truly the true inflammation, and it usually we see because of that some toxic effects, not of the infective etiology. And what are the potential causes for the TAS is something which is related with sterilization or some medication or intraocular things, drops and ointment. There are many causes, but we have to only concentrate on the first one. And this endophthalmitis is having different etiology. Either it is bacterial, viral or fungal, but it is, we can say at present that TAS is of non-infective etiology and endop is of infective etiology. And based on that, endophthalmitis is divided into different types, whether it is endogenous or exogenous, acute or delayed. This classification we all know. I am skipping this. But TAS and endop, again, what is the problem? Problem is that both can appear almost in early endop and the TAS at the same time set, means after the same duration, but treatment is not same, etiology is not same. Clinical features mimics with each other, but how to treat this and what is the difference between etiology is separate. So with these two conditions, this is a simple chart we can tell you. Even the TAS, the onset is within 48 hours and endophthalmitis is usually 4 to 7 days. Sometimes later on, a delayed endophthalmitis can occur after 4 weeks or 3 weeks of fungal or another etiology. But one is important difference is onset. Another one is the pain. In the TAS, patient usually didn't complain of any pain or mild diffuse pain, but in case of endophthalmitis, pain is more. Then you have seen the discharge, And lid reaction. Lid reaction is something which is obviously seen by some expert that yes, in case of endop, it is more. And when we compare the anterior chamber, then anterior chamber reaction is usually less in endop but more in TAS. And this is something feature which is very much important, and everyone can know the corneal edema. It is I can say what are the differentiating factors clinically. This is we can see most important and usually found in all that. In case of TAS, you have seen here complete limbus to limbus edema, and in case of endophthalmitis, it is either localized or segmental, but usually the cornea, you can see something from the through the cornea. But in case of TAS, it is usually difficult, and you have seen this is the something feature which is differentiated between both. Coming to the IOP, IOP may be normal in both cases, but usually in TAS, it may be of higher side and endop of the lower side. And vitreous, again, if you are able to see the fundus, then it is a clear-cut indication that in case of TAS, vitreous is clear, and whenever is endophthalmitis, there is vitritis or vitreous hemorrhage. So I suggest at least these two features, limbus to limbal corneal edema and vitritis, these two are the important thing which we have to differentiate, and usually these two can differentiate both features easily. Another thing difference, whatever we can do in the management, I am not going in detail, just giving some silent point that whenever is the endophthalmitis, you have to take an extensive and aggressive treatment for intravitreal and topical antibiotics, and whatever the guidelines of endophthalmitis vitreous study, you can go through. But in case of TAS, always rule out what is the infection. Never treat or say that it looks like TAS, so I will not go for that. Until unless you rule out the infection by culture sensitivity or whatever the method, always, as Dr. Mathur sir suggests, if there is a doubt, you always have a fear, or since endophthalmitis is more dangerous, so think of the more dangerous thing, but you can monitor it and closely. With this, just a take-home message, we have to see what is the time of the onset, corneal edema, anterior chamber reaction, and vitreous or vitritis. These 3-4 important features can help you in diagnosing these two clinical cases. With this note, I would like to thank you. Thank you.
Thank you very much, Dr. Deepak. If there are any questions, we'll take them at the end of the session. Next talk will be by Dr. Haimanti Choudhury. He'll talk on medical management and intravitreal injections. Again, for those who have arrived late, if you want a handout of this session, it is there right in front of the dais.
Like this, you have all the information about this. Whatever we are talking, this is related. So as Dr. Deepak said, I again repeat it, if you are in doubt, always treat case at the end of endophthalmitis. Do not take a chance.
Very good morning to one and all. At the very outset, I'd like to thank AIOC, the scientific committee, Dr. Deepak Mishra, Dr. Satanshu Mathur, Dr. Ajay Arora, Dr. Jalpa, and Dr. Haimanti for giving me this opportunity. We are all scared of this picture after a well-done cataract surgery or any other intraocular surgery. But once we have it, we have to know how to treat it. So what are the goals of treatment? To kill the invading organism, to arrest the damage by the exotoxins and endotoxins, and to arrest the host inflammatory response. What options do we have? We have the option of antibiotics in multiple routes, surgery, that is pars plana vitrectomy, and steroids. Now, intravitreal injection is the only surefire way to know that the drug will reach the vitreous cavity in the required concentration. Topical drops, subcunj injections, they are not adequate. You have to go for an intravitreal injection. Also, we use systemic medications. We will talk about that in the subsequent slides. Most of our knowledge of endophthalmitis is based from the results of the EVS study, but it came out way back in 1995. And there was a very important caveat. The EVS study included only those cases where the cornea was clear enough to perform a pars plana vitrectomy. So it means most of the very aggressive organisms were excluded from the study. Patients who had a corneal infiltrate were excluded from the study. So, however, the EVS study concluded that there was no role of systemic antibiotic, that immediate pars plana vitrectomy is not required when the visual acuity is better than PL, and only when the patient have a visual acuity of PL or less, only then you should go for a pars plana vitrectomy. However, there has been some it's not playing. Achha, nahi, it's playing, yeah. It's playing over here. So we now have to see what the role of systemic medication is. There are certain disadvantages. It prolongs hospital stay. It increases the cost. It might have some systemic side effects. But the ground reality is that most ophthalmologists feel more secure using an oral antibiotic. And systemic medications also prolongs the duration of the inhibitory concentration of the drug. And there is a better chance of killing all the viable organisms. There was a major review published in Survey of Ophthalmology in 2017. They showed a modified EVS protocol where they mentioned the algorithm of how to treat a patient with endoph. So the moment you diagnose a case as post-op endoph, a vitreous tap and an injection is essential. And they also mentioned the use of oral antibiotics, moxifloxacin or linezolid. Once the initial treatment is done, we assess the clinical response after 24 hours. If there is a satisfactory response, then we go ahead with the same treatment. And if there is a poor response, then an urgent vitrectomy is indicated. There is no role for a repeat intravitreal injection. Now, these are the most commonly used oral antibiotics, but we prefer ciprofloxacin, 750 milligram, 12 hourly. These are the organisms which cause endoph. Coagulase negative staph and delayed is mostly caused by Propionibacter acnes. There are certain indicators which indicate a very virulent organism. That is symptoms within 2 days of surgery, a light perception vision, APD, wound abnormalities, corneal infiltrate, loss of red reflex. Now, about the choice of intravitreal antibiotics, it actually depends on what organism you are suspecting. Now, for gram-positive, vancomycin is still the drug of choice. For gram-negative organism, although ceftazidim is considered to be the first choice, but still, in case of very virulent organisms, we now go directly for imipenem or piperacillin tazobactam. This is because, although most gram-positive are still responsive to vancomycin, but the case is not the same for gram-negative organisms. So if we look at studies from across the world, we see that in India, the organism profile is not the same as they find in the West. Here we have a very high percentage of patients who have a gram-negative organism. And among those organisms, a very high degree of resistance to ceftazidim and amikacin. So in those cases, when you are suspecting a gram-negative organism, we actually go for imipenem or a piperacillin tazobactam combination. Another important thing to know is that we should be aware that there is an entity called fungal endogenous endophthalmitis, mostly seen in COVID patients. So we have to know this entity because if we treat it as a non-infectious case with intensive corticosteroid therapy, things can get really worse. Now, vitreous biopsy is the suggested way. Vitreous tap is not recommended because vitreous biopsy avoids retinal traction, it avoids a negative tap. And it's not a very difficult procedure. I'll be showing how to do it. And alternatively, AC tap may be used. So everyone should actually perform a single port vitreous biopsy because it yields undiluted sample, especially when the visual acuity is better than PL. When you're not actually planning a pars plana vitrectomy initially, a vitreous biopsy is definitely essential. So These are the instruments which we use for vitreous biopsy. So I'll be showing how exactly to prepare the drugs. So I'll be talking about the preparation of vancomycin. We desire the concentration of 1 milligram in 0.1 ml. So vancomycin is available in 500 or 250 milligrams vials, and we initially have to dilute using 10 ml of sterile water for injection. So this is mixed with the vancomycin vial, and we have to mix it very well. And one point to remember is that we have to keep a lot of needles, because we'll keep on changing needles at every step. So we draw 0.2 ml in a separate syringe. Then we make it 1 ml using distilled water for injection. But at every step, you'll notice you have to change the needle. So you need at least 10-15 needles with you to prepare 2-3 drugs. You mix it using this motions and allow an air bubble to move up and down the syringe. Then you take 0.1 ml, so that contains 1 milligram of the drug, cap it, and you also mark it to know which injection is which. Next, we'll be moving to the preparation of Ceftazidim. Ceftazidim again comes in multiple concentration. We desire the 2.25 milligram in 0.1 ml. So for a 1 gram vial, we usually use 4.4 ml of distilled water for injection. Again, first we mix the distilled water along with the Ceftazidim vial. Then take a new needle every single time. Take 0.1 ml initially, then make it 1 ml. At every step, very important to remove the needle, because otherwise the concentration is changed. Again, we have to mix it using this round and round motions, and keep finally 0.1 ml, which contains 2.25 milligram of the drug. Going to the vitreous biopsy proper, endoff is a very painful condition, so it's always advisable to do a perivalvular block in these patients. So it's done in the usual way, but very important to note that we should not put any pressure on the eye, because these are post-op cases. Any pressure on the eye can lead to a wound leak, which is not desired. Dressing and draping is done like we do usually, using povidone iodine. We put in a speculum. Here I'll be talking about preparation of the vitrector. So a vitrector comes with every phaco machine. Initial few steps are same. You have to put it into the machine in the way they have mentioned. Use aspiration and irrigation, and the rest of the steps are very similar. You have to put in a separate needle, but we don't use the infusion at all. So initial priming is done as usual. Only thing is, you need this yellow adapter. It comes with any IV cannulas. You use it to basically aspirate out the vitreous sample. We do not need the infusion, so you have to keep it separately. Now, use a trocar to mark 3.5 millimeter from the limbus. If you do not have access to a trocar, MVR, you can use a MVR to make the port. So single port vitreous biopsy is not a very difficult procedure. Once the port is made, we have to be sure that the cutter is actually cutting. So you first of all check the cutter, and only then you have to put the cutter inside the eye. Initially, you start with cutting, and then tell your assistant to start aspirating after a little while. So we do not need too much of a sample. Only 0.5 ml is adequate. Or the moment you notice any hypotony, you have to stop aspirating. Once the sample is collected, you have to cap it and send it immediately for the microbiological evaluation within at least 30 minutes. So you have to cap it, and we bend the needle as well, and immediately send it off for evaluation. Now, doing the injections, you need separate needles, separate syringes, because these drugs interact and can form a coagulum if you use the same syringe. So you have to do it separately. Injection is done very slowly in drop-by-drop fashion. Once the injections are done, we always try to keep the eye slightly soft so that it's not very hard. Once the injections are done, just check whether it's a self-sealing or not. And if it's self-sealing, then fine, but otherwise, suture can also be placed. So even very virulent cases do well with just a vitreous biopsy and an injection. So there are certain indications where we directly go for a pars plana vitrectomy instead of the vitreous biopsy and injection. So when the visual acuity is very less, PL only, a suspected highly virulent organism, when there is no response to intravitreal injection, in post-traumatic endophthalmitis and fungal endophthalmitis, we directly go for a pars plana vitrectomy. Also in delayed endophthalmitis. So I'll just be touching upon a few steps. Make sure that the infusion cannula is inside. Make sure you can actually visualize the infusion cannula. If you need, you can actually clean up the AC if you have to do that. And we perform a very limited core vitrectomy. We do not need to do a PVD induction, and just the posterior pole should be visible. The moment we can see the disc and the posterior pole, we stop. We do not need to perform an extensive vitrectomy. For most cases, just a limited core vitrectomy is good enough. So once the core vitrectomy is done, the moment I see the disc and macula, we'll stop. Once that is done, we remove the other trocars and we do the injections like we mentioned. Again, if there is any doubt, you should always be ready to put in a suture. So this was a traumatic end-off, but patient did very well. So one thing you all should know is this E-kit from Oral Lab. So E-kit actually has all the medications and all the equipment necessary for the injection. So everyone should at least have that E-kit with yourself. So about the role of steroids in bacterial endophthalmitis, definitely there is a role. It helps to reduce the host inflammatory response. And it can be given in multiple routes of administration, that is topical, systemic, even intravitreal. But for fungal endoph, we do not use steroids. These are the microbiological workup that needs to be done. Delayed post-op endoph, again, need a pars plana vitrectomy and also sometimes lens removal, explantation, because only injections, they have a very high recurrence rate. So to summarize, early diagnosis and management can save most eyes. Intravitreal injections, Vancomycin and Ceftazidim are still used in acute endoph, unless we are suspecting gram-negative, when we use imipenem. AC tap or a single port biopsy is good for microbiological workup. And in patients who fail to respond to initial therapy, no use of doing another injection. We have to go for a vitrectomy immediately. Thank you very much.
Thank you, Dr. Haimanti, for this extensive talk. Mainly the preparation of that intravitreal drugs and all. I'm sure it will be very helpful for the audience out here. Now, Dr. Jalpa Vashi will be speaking on NABH protocols in endophthalmitis. So in addition to the AIOS guidelines, we also need to have an idea of what the NABH wants us. So Dr. Jalpa's talk will be dealing with just that.
Good morning, everyone. And I would like to thank Dr. Haimanti for the opportunity. So, endophthalmitis, in fact, none of us would like to have it. But in case, unfortunately, if it happens, then how many of us are prepared to tackle the same? So, let us learn a couple of guidelines laid down by the NABH, which will help us in preventing the infection and will safeguard us with proper documentation in case the infection happens. Now, who is responsible when endoph happens or any kind of infection happens? Is it the operating surgeon, the OT nurse, CSST in charge, the OT support staff, or infection control nurse? Or altogether consumables like BSAs, intracameral drugs, IOLs, or it can be process failures also. There can be improper validation of sterilizers. There can be failure in indicators. if the surgical safety checklist is not executed properly, if reuse policy or multi-dose vial policies are not defined, then all this infection can happen. Or the entire infection control program, which would lay down all these policies. So in NABH, there are 10 chapters. Out of 10, 4 chapters would guide us regarding infection control policy, documentation, and quality assurance. So let us first learn a couple of guidelines which will help us in preventing infection. Now, in inpatient record, this is discussed by Dr. Mathur. Couple of things are mandatory to be mentioned as per guidelines, like negative history of MGD or sac block, any systemic illness or uncontrolled infection. Consent is very important. We know that is a legal document and it should be filled properly and it should be bilingual also. Surgical safety checklist, we'll discuss this. Operative notes, IOL implant details. So the IOL label which carries the details should be pasted at 3 places. One is the OT master logbook, another one is your discharge summary, and then inpatient record. Post-operative care plan, which will include your antibiotic protocol, and discharge summary. Here it is very important to mention about how and when to obtain an urgent care in case if some untoward things happens. And this should be in the language which patient understands. So this is the surgical safety checklist, which is laid down by WHO in order to provide safety for all the patients who are undergoing surgeries. Now, this can be modified as per our need also. Here you can see the 3 phases: sign in, time out, and sign out. Sign in is before induction of an anesthesia, time out is before incision, and sign out is before patient leaves the operation theater. Now, in sign-in, you have to identify the patient's patient and patient's site of surgery, and again consent. In time-out, your nursing staff will review the indicators and also the antibiotic, whether it is given as per the protocol, the prophylactic antibiotic. Here you can also include the verification of IOL power. You can also include the verification of all the vials or consumables which are going to be used. Coming to operation theater, Dr. Haimanti is already mentioned, but avoid mix of sterile and unsterile stuff, and there should be SOP on safe usage and sharing of consumables to ensure the safety when we are sharing the consumables like BSS, Trepan Blue, or any intracameral drugs. And documentation of each consumable should be mentioned in the surgery patient record. Coming to quality assurance program regarding OT surveillance, the efficacy of the OT cleaning and disinfection practices should be ensured, and this should be ensured by taking OT cultures. As per guidelines, once per month we are supposed to take OT cultures, but if there is a heavy load, then you can take once in 15 days. AHU monitoring, it should be daily for humidity, temperature, and pressure differential. The integrity of AHU filter should be checked once in 15 days. And CSST surveillance. Now, we assume that when the indicator changes the color, the process is executed properly, but it is not so. It just indicates that process is completed. It doesn't tell you that whether the temperature or pressure is given for that particular holding time. So to validate the sterilizer, we have to use Bovidic test that is generally used during the first load of your sterilizer, and biological indicator as per NABH guidelines, which should be used once in 15 days. Multi-dose vial policy. So couple of drugs which we use or we share it for patients like antibiotics, lignocaine, anti-VEGF, Vancomycin. We must prepare SOP in which we are supposed to mention how we will ensure safety when we are using in couple of patients, and safe storage after opening of the bottle or vials, and we have to mention the date of opening when we open any vial. Now, infection control program. This manual we are supposed to prepare as per NABH guidelines, and so many points we are supposed to cover, like say standard and universal precautions, which would include your hand hygiene, safe injection practice, any blood or body spillage, needle stick injury, PPE, or even post-exposure prophylaxis, sterilization. You have to define high-risk areas in your hospital. Which all are high-risk areas? Your OT, CSSD, your biomedical waste disposal area. Then there should be a protocols on cleaning, disinfection, and sterilization. There should be a surveillance activities like validation of your machine and cultures. Risk identification and management, we'll discuss this. Antibiotic policy, use policy for certain instruments. Budget, now your management must have dedicated budget for the hospital, and it demonstrate their interest in executing the infection control practices. KPIs, this is the key performance indicator to monitor all these processes. For example, adherence to hand hygiene. And trainings, frequent trainings on infection control practices is really required. Training is one of the major pillar in NABH. There should be an infection control nurse in your hospital which would supervise all these processes, and would arrange for the trainings. Infection control team, which should include microbiologist as one of the member. This team will make all the policies. An infection control committee. This committee will review all the policies, and it will also discuss any adverse event if it has happened. The committee has to meet once in 4 months. Now, what is risk identification and management or risk reduction protocol? So this is to minimize the chance of infection in eye, and for this we'll include all these points, like the surgery prerequisite in case of high-risk surgeries or people who are having who are HIV or HBS positive, and there should be the antibiotic protocol should be included. The preparation of patient before surgery, care during surgery, post-operative care with antibiotics, schedule follow-up, the early detection of surgical site infection. We must include the disinfection protocol before, in between, and after surgery. There should be a stringent OT etiquette for staff and doctors. Surveillance protocol, key performance indicators, and OT infrastructure as per NABH guidelines. Reuse policy, so couple of instruments like phaco tips, sleeves, vitrectomy cutters, cassettes, we reuse, right? So we have to make SOP, we have to list out all these items which we are supposed to reuse, how many times we'll reuse, and we have to mark the item after every use. And frequent quality check should be done for any kind of damage. There should also be a policy to discard early in case damage happens. Many registers and records are supposed to be maintained in OT, but most important ones are OT culture reports, the sterilizers indicators reports, validation record for all the sterilizers, recall records, consumables used during the surgeries, OT master logbook with implant details, AHU maintenance record, AHU daily log, and your checklist for OT disinfection and OT cleaning record. So now coming to the management in case infection happens. So surgical site infection, so in NABH, the endophthalmitis is also known as surgical site infection, and as per CDC definition, infection occurs within 30 days after the surgery if no implant is left, or within 1 year if implant is in place, is known as SSI. Now protocol, we know, we do complete recall of all the patients, instruments, and consumables after sealing the OT. We observe other patients, operator on that day. We need to verify the sterilization indicators and check all your CSSD records, re-sterilize all the items, check all your intracameral drugs or consumables used, check register also, and inform the vendor. Check IOL details, redo OT de-infection, and again culture and validation of sterilizer machine is required. And entire thing should be documented in detail with investigations and treatment plan. And do not forget to recheck your consent. Now this end-off is kind of incident, and any incident as per NABH protocol we are supposed to note. or it is reported at incident reporting. And when incident reporting is done, we have to first do root cause analysis and then take some corrective and preventive actions. Now, how we do root cause analysis? There are various methods. We'll learn two simple methods. One is 5 why method. You keep asking why for a couple of times till you get the answer. Now, suppose infection has happened. So, why infection happened? Because protocol was not followed. Why it happened so? Because there was a lack of awareness. And then last you come to conclusion that there is a lack of communication and callous attitude by the staff. Now, how to rectify this? So, you have to impart frequent training. Keep taking training, teach your staff and make them understand how important is the infection control practices. Now, another method is fishbone analysis, where we break down the root causes. Suppose there is an endophthalmitis, you can see it is the another subgroup is breach in sterilization, where you can include like there was no validation of your sterilizer machine, or there was a failure in indicator, right? Endogenic factors like uncontrolled diabetes, or there was kind of systemic illness. Contaminated solutions or drugs, we couldn't find any visible dirt which was ignored. Mixing of sterile and unsterile instruments, or inefficient disinfection. We don't have any protocol in disinfection, or that day the AHU failure was there. Okay. So when adverse event happens, again after doing root cause analysis, we have to take corrective actions and then preventive actions. So what are the corrective actions? We know we treat the patients, we do OT surveillance, CSST surveillance, again instrument, consumables, and medicine recall. And prevent actions to prevent infection to be happens again in future. So here we need to change the policy, change your cleaning, disinfection protocol, sterilization and instrument cleaning protocol, change the consumables. You can change your supplier vendor and alert your colleagues regarding the faulty consumable. Document entire process, and during the committee meeting you are supposed to discuss this and make new policies. Again, you must impart training to your staff with new policies and procedure, and the most important thing is review of training effectiveness. So frequent training and feedback is required from the staff. Thank you.
Thank you, Dr. Jalpa. And now we have the last talk of this session, surgical management of endophthalmitis. It will be dealt with by Dr. Ajay Arora. And after that, we would be happy to take any questions if you have about this session. Dr. Ajay Arora is the vitreoretinal surgeon in Vision Eye Plus Center, Noida. And he is also the joint treasurer of All India Ophthalmological Society.
Thank you, Martin. It's wonderful to be part of your course. Good morning, everyone. And I've been involved with this course for the last 2 years, and it's been growing. It's been really fantastic the way it's grown. Right. So, is surgical management of endophthalmitis, when do we do vitrectomy in endophthalmitis case? We don't want our eyes to end up like this. We would definitely want a surgical output like this. Aim of my presentation is to understand the indications for pars plana vitrectomy, how much vitrectomy we do in a case of endophthalmitis, what one should avoid doing in case of a in vitrectomy. So I'll rapidly run through. So we get cases which are really bad. What Haimanti showed was cases which are much cleaner. We get cases where you have a membrane in the pupillary area. You have to remove them before you get inside the vitreous cavity. So you will see here that AC Mentorian has been put, and then with a bent 26 gauge needle, we tease off the membrane from the pupillary area. And once that is done, it is very gently removed. And once you can see that it is being removed, and then we go ahead and do the vitrectomy. The aim of vitrectomy is to ensure that this is a slightly older video, but in case required, we always, if the choroid is thickened, we still use a sutured 6 millimeter cannula. We use MIVS. We have 6 millimeter MIVS cannulas available, but whenever we are not sure, we must make sure that the cannula is visible inside before a vitrectomy is started. And the endpoint for vitrectomy is that we should be able to see the disc or get a very good glow. Please remember, the fight with endophthalmitis is by antibiotics. So vitrectomy basically is debulking the vitreous. This is another situation where so I use this fixation device, which is my own device, which is used also as a device for giving intravitreal injections, and do a vitrectomy. Again, the endpoint, as been shown before, is to ensure that we have a very clean vitreous with the disc visible. So the indications for pulmonary vitrectomy classically by EVS is light perception only, hand movements, very virulent infection, progressive course despite initial intravitreal antibiotics, delayed onset endophthalmitis, fungal endophthalmitis, recurrent endophthalmitis, endophthalmitis with the retinal detachment, endophthalmitis with a corneal perforation or an intraocular foreign body. And so it is important that Haimanti has shown how we remove the fluid. So you can have either cutters which can directly get connected to the syringe, or you may have to put in a small rubber adapter which you can get from your IV set, and that is used for connecting. So the vitrectomy basically works by providing us material for culture. It reduces the toxins and the organisms. It clears up the media, so basically it debulks it. And then there is a uniform distribution of antibiotics. The final fight with the organisms is by antibiotics. Vitrectomy only helps us in that fight. These are some examples of patients and acute endophthalmitis which was treated, visual acuity improved. So the poorer the visual acuity we start with, we end up having a visual acuity proportionately like that. The better the visual acuity we start with, the better the visual acuity we end with. Now, if we look at the history over the last 23 years since the EVS came in, there has been a sea change in the way the vitrectomy is done, the fluidics in a vitrectomy machine. And there's a recent study from China which showed that if you do an earlier vitrectomy, these cases actually do better. So the indications have over a period of time changed. Now here is a patient who had, it was a P. acnes endophthalmitis with a plaque. So we went ahead and gave an intracameral voriconazole. We did a vitrectomy, created a posterior capsular cut while doing a vitrectomy, did a lavage of the AC and did a vitrectomy. P. acnes was grown, patient was treated with intracameral and intravitreal vancomycin, and patient did well. So these cases, if you are able to remove the organism completely, they do well. This is a series of cases of fungal endophthalmitis who presented with the signs being more than the symptoms. These patients underwent an AC wash, a vitrectomy with voriconazole, 25 microgram per 0.1 cc, and intracameral injection of voriconazole, and this was the result. So these patients did well. You have to intervene early, intervene with an antifungal agent, and it must be correct. This was a patient who was a golfer, had a little bit of floaters. We were surprised that even an aspergillus, which actually should present a little bit more aggressively, this came up after we did a yak capsulotomy. We were able to grow this on a lactophenol cotton blue and a Saburos dextrose agar, and the organisms were identified. This was a patient with an intraocular foreign body which grew pseudo-Escherichia boydii, and this is a very old slide of mine. If you can see carefully, this is way back in 2003, almost about 20 years back while I was at Schroff. So this patient, we did a radical vitrectomy, and it grew pseudo-Escherichia boydii. So whenever we have a patient of an endophthalmitis with a retinal detachment, though it is uncommon, we have to do a vitrectomy. In these cases, the vitrectomy has to be radical. We put in silicone oil injection. We do a laser into photocoagulation, and an intraocular antibiotic is given after the fluid exchange, before the injection of silicone oil. If you have a corneal perf, then either you can do a keratoprosthesis followed by a pars plana vitrectomy and end up with a therapeutic PK, or you can do a therapeutic PK, you can do an explantation of the IOL or an open sky vitrectomy followed by a therapeutic pars plana vitrectomy. There has been a role of steroids, and it's been very well documented by the LVP group, and this is courtesy Dr. Das and Dr. Patange, where you can, so in these cases, they have used triamcinolone, which I would not recommend on a routine basis, but please remember that bacterial endophthalmitis, use of steroids is indicated to reduce the inflammation. There is now a lot of talk about the inflammatory score in a case of endophthalmitis. Higher the inflammatory score, worse the prognosis. Lower the inflammatory score, better the prognosis. It is also being talked about the biofilm formation. We will not go into those details, but whenever you have an endophthalmitis post-Avastin or post-Ozurdex injection, it requires an urgent vitrectomy. Do not postpone these cases and give intraocular antibiotics. If there is time, if you do not get time enough to go ahead with the vitrectomy the same day, definitely go ahead with intraocular antibiotics, but intervene very early. So these are some of the interesting cases I'll just share with you. So this is a patient of a type 2 diabetic, post-op day 1. Patient underwent an intravitreal injection of Vanco and Tazobect. Patient underwent a revitrectomy with Vanco and Amikacin, did not respond, so patient took a second opinion, and patient underwent a revitrectomy with voriconazole. Vitreous sample was then sent for PCR. So the aim is that we should utilize the facilities of PCR more often. And this is what happened. Patient grew Bacteroides fragilis. Patient was treated with intravitreal injection of imipenem. And so therefore an organismal diagnosis is very important, whether it is done by culture or whether it is done by PCR. Another case, you can see patient got Vancomycin, we had a vitrectomy with imipenem. This was microscopically, microbiologically negative. We did a revitrectomy with PCR and added linezolid. Patient grew on PCR, Pseudomonas aeruginosa, was treated with colistin, and patient did well. So this is a patient whom we followed up for now about 6 years. Patient presented in 2009, underwent a phaco IOL, had developed endophthalmitis, was treated with Vancomycin. 2010, other eye got operated, and then patient had persistent endophthalmitis, was treated at a large institution as a patient with uveitis, underwent about 14 injections of Avastin, 6 injections of methotrexate, and then patient came back to me and we had to do something. So we were not sure that whether it's a masquerade or it is something else, so we had to get a sample. The basic aim is we have to have an organismal diagnosis. So in this case, we did something unusual. We took a 32 millimeter long 26 gauge needle, which is used by thoracic surgeons. We went in and went into the area of the zonules, because this patient had undergone 3 vitrectomies and yet was having a recurrent endophthalmitis. So you can see here with this, I go into the periphery. I also take an intracameral fluid, and then we went ahead and did the vitrectomy, in this case revitrectomy. And these are the various steps, and we sent the sample to 2 different places. We sent it to Bangalore for Exciton, and we sent it to Shankar Netrale. The Shankar Netrale sample grew P. acnes, and Exciton grew Fusarium. What do we do now? So anyway, we treated this patient both with anti-fungicidals and vancomycin, and patient since then for last 6 years has done well. I do not know what worked, and there's a recent report of a similar organism of an experience in the US. I will not go into this details. This has already been talked about. Just to tell you, in India, 47% of the infections are by gram-negative. Most are still by gram-positive. This is not what the EVS said. The Indian situation is different. We have to use one antibiotic for positive, one for negative. There is an increasing resistance to Ceftazidim. There's a study published by LVP recently. The resistance to Ceftazidim is almost 60% in the cases which reach what LVP has published. So many of us are combining Vanco with Tazobect, but yes, Ceftazidim still works, and we should continue doing that. So the take-home message is take all steps to prevent endo from occurring, differentiate Taz from endophthalmitis. When in doubt, as Dr. Santanshu said, err on the side of infection, use intravitreal antibiotics early. If it is bacterial, start steroids, systemic antibiotics, complement intraocular antibiotics. You must do a timely, which is early, judicious vitrectomy. You must document all your findings. Talk to the patients again and again and the family. And remember, the eye saved is you're saving yourself all the problems. So spend a lot of time. So these are some of the things which I already said, but most important is in a vitrectomy, do not try to induce a PVD. With the newer cutters, with the newer phacofluidics, with the vitrectomy fluidics, we can go and shave very close to the retina, so we can do a much better vitrectomy. And you should reduce the suction and try to use cutters which are newer rather than always using older cutters. Thank you.
Dr. Arora, I have just one question.
Yes, sir.
When you are injecting silicone oil, in case of endophthalmitis, do you change the concentration of the intravitreal antibiotic?
So I have, what we have done is we really don't change the antibiotics concentration much. People have said that you must make it half. I give the antibiotics at the end of fluid air exchange. I don't do it within the silicone oil. But in case I have to inject antibiotics subsequently in a silicone filled eye, then you can reduce it.
Any question from the audience? Mike.
Suppose the patient was left aphakic during a surgery and he lands up into endophthalmitis, and you have to, after treatment of endoph, you have to plan for a secondary IOL. So the type of IOL which you will choose, and after how long after recovery of endoph will you plan for a second surgery?
So ma'am, there are two questions there. One is, when do you plan to decide to do a secondary IOL and what type of IOL? So you must treat uveitis as a form of inflammation. The standard rule of treatment of any inflammation is the eye should be quiet for 3 months. Minimum 3 months. That means you should have zero flare in treating these cases. So I would say that if a patient has had endophthalmitis and a vitrectomy, it will roughly take 5 to 6 months before you can try to plan to do a vitrectomy. Plan to do a secondary IOL. My choice in these cases, I still prefer to do because I'm quite comfortable with it, I do a scleral fixated IOLs. But you can certainly go in with an ACIOL. I have no objection to it, and I would like to take opinion from the panel what they think. But that is my choice, ma'am. Mike.
Are there any chances of any patient?
Okay, since I'll just cut you. Since the next instructors are here, I'm sure sir can take the question.
I'll comment on it.
Because we don't want to drag our time. Thank you very much for the attendance.